Good morning. So two of us are going to talk about next-gen sequencing. Mickey Williams, who's going to be presenting after me, will be talking about the validation of the assay. And I'm going to be speaking about some of the challenges that we have from an implementation perspective in using this information in the clinic. So as you've heard today already, biomarkers are prevalent throughout the continuum of cancer care. At the time of diagnosis, treatment selection, treatment plan management, and response assessment. And these biomarkers all have different classifications, whether they're a risk biomarker, a diagnostic biomarker, a prognostic biomarker, or a predictive biomarker, which is what you were hearing most about today as far as predicting responses to drugs, or response biomarkers. And there's a lot of different decisions that providers need to be able to make when they're trying to navigate this sea of biomarkers, which is which tests to order and when, and how to interpret those and report those results, and most importantly, how to apply those results to patients when you get them. And from a decision support perspective, there's a lot of different types of modes of decision support that you can provide. When to provide that decision support, how to provide it, and to whom are all open challenges in this space. As you've heard already, we've gone through a history prior to the 2000s where, especially in difficult to treat diseases like lung cancer, we were treating an unselected population whereby we had no biomarkers to differentiate individuals, and we treated everybody with in the exact same way and had abysmal responses in only a small fraction of the patients. This is where we were in 2002. This was one of the seminal papers published on non-small cell lung cancer comparing 4 platinum chemotherapy doublets, where you can see that there was not a difference in the survival curves between any of these 4 treatments, and the median time to progression was only 3.7 months and an overall survival of 8 months. We weren't doing very well back in 2002. And as you've heard already from Bruce, EGFR came along, and this is one of the first seminal papers in 2009 comparing EGFR mutants versus non-mutants and their responses to gefitinib, and now for the first time we're really starting to see some separation between those 2 curves. So what this has changed is our approach to diseases like non-small cell lung cancer, where previously we were treating an unselected population all the same way, and now we have predictive biomarkers where we can subset this population, and now instead of treating everybody the exact same way, we segment out this subpopulation and we treat them differently with a targeted therapy. And now instead of having response rates of 30% or worse, we're getting response rates of close to 80% in this population. And those who are responding in the first-line setting we call as having primary sensitivity to the drug. Unfortunately, it is still not a panacea. There are still some primary resistance to those medications in a smaller population, and we're finally beginning to understand some of the diverse mechanisms whereby resistance in the primary setting can occur. Unfortunately, in the advanced metastatic setting, almost all of those patients will ultimately go on to have disease progression. And we call this acquired resistance to targeted therapies. And as in primary resistance, we are now beginning to really understand some of the mechanisms whereby patients are getting acquired resistance to targeted therapies and developing novel therapeutic strategies, both to try to overcome primary acquired resistance at the very beginning of treatment, as well as treat patients in the second line and beyond once they have actually acquired resistance. Now, many of these discoveries of acquired resistance and primary resistance have been made because the cost of the genome has gone down. And as Bruce mentioned, some of these large-scale genomic testing efforts have facilitated our discovery of these co-occurring alterations in cancers, as opposed to just testing for the single biomarker that's going to drive your decision for therapy. We can now test for multiple types of alterations. And although this is showing that the cost is somewhere in the less than 10,000 range for an entire genome, as Bruce alluded to, we can do smaller gene panels which still cover a wide range of cancer-specific genes, and the cost is coming down. But what this has resulted in is a tsunami of genetic data entering into the clinic at a pace that we've never seen before as providers. It was one thing when we were doing these single mutation analyses that Bruce talked about. Well, you were looking for a specific thing, and if it was there, you were gonna act on that piece of information, and you knew what you were supposed to do. Similarly, with hotspot panel testing, which came around 2009, we had a select number of genes, and there were the standard of care genes and then a few additional ones for which we already had targeted therapies either in the clinical trial pipeline ready and available to go. So you had a decision that you could make on that information. But now with next-gen sequencing, we're testing hundreds of genes all at the same time. And we do not know what to do with all of that information that's coming into the clinic. And when I mean into the clinic, it's one thing to do it in a research setting. It's a whole other thing to be doing this in a clinical environment where all of those results are actually coming in as part of a report for patient care. So clinicians are clearly overwhelmed with this information. Some are staying away from it because they are overwhelmed. Others are trying to embrace it. But ultimately, we're all stuck in the middle of having this massive knowledge gap of what we're supposed to do with all this information coming at us today. On top of it all, there's variable levels of evidence for each of these biomarkers that we're testing, ranging all the way from only preclinical data to information that has clinical validity and that which has clinical utility. I believe this is going to be discussed in more extent later today, where clinical validity separates one population into two or more groups with distinctly different outcomes, but that doesn't necessarily mean that you treat them any differently. It just shows that they are different from one another, whereas clinical utility, that information can now be incorporated into a standard of care clinical decision that may have a prognostic or therapeutic implication. And the evidence ranges from animal models and cell lines to case reports, retrospective cohort studies, non-randomized prospective studies, and finally into that clinical utility realm of randomized prospective studies that can then become part of FDA approvals and clinical practice guidelines. Back in 2004, when we were doing our single gene analysis panel at Vanderbilt, this is how we were reporting the results in the electronic health record. It was a scanned document. We had these templates. We had one gene that was tested for EGFR, and you're not supposed to be able to read it except to see that it's a massive blob of text, which talks about the quality of the assay as well as what you might do with that information. Imagine now going from this amount of information for just a single gene to now reporting on hundreds of genes with thousands of variants. Whose role is it to curate this knowledge regarding the clinical significance? It's overwhelming to try to keep up with all of this knowledge. And furthermore, these reports lacked any information on clinical trials that might be important in this setting, which, if you're doing all of these additional genes that you're testing for, is really the only actionability for the majority of the assays that you're testing. So in 2011, we tried to address some of these challenges by creating a knowledge base called My Cancer Genome, the mission of which is to curate and disseminate knowledge regarding the clinical significance of genomic alterations in cancer. And I'm going to spend a little bit of the rest of my time talking about how we're curating that information and disseminating it. My Cancer Genome consists of several different parts. It's a publicly available website. The first part is a manually curated set of content over 21 different cancers and over 56 different cancer-related genes and over 400 different disease gene variant relationships. Here's an example of what one of those pages looks like. This is for EGFR T790M mutation in non-small cell lung cancer, which actually confers resistance to EGFR tyrosine kinase inhibitors. We provide information on the location of the alteration in the gene, the frequency of the alteration in that particular disease, and the response to drug, which is sensitivity or resistance to those particular targeted therapeutics. Unlike clinical practice guidelines, My Cancer Genome contains information at multiple levels of evidence, the ones I've just shown you earlier. We are not trying to be an FDA approval process. We are really trying to be translational. So our threshold is that so long as the drug is being used in an inhuman clinical study, we will include it on our resource so that people can understand the potential actionability of some of these alterations that they're finding. And when that happens, we will include preclinical studies should there not be any inhuman studies available. My Cancer Genome also contains a search for clinical trials that are gene-directed. We download the PDQ clinical trial database with over 40,000 clinical trials that contain information of over 135 different cancer diagnoses and 500 cancer genes. One of our most popular features is a cancer drug targets list with over 500 cancer-related genes and their respective genetic targets. And finally, we have a rare mutation database, which is a publication of case reports of drug response, which I'll talk a little bit about later. As far as how we prioritize content on My Cancer Genome, we initially started our program with the focus of therapeutic implications for cancer, where we were really looking at sensitivity and resistance mutations that had the highest clinical utility and the highest size of effect. We do include some prognostic and some diagnostic biomarkers as well, and we're starting to flesh out our content in that area. Now, as you were hearing about earlier, there's a lot of different types of biomarkers. They're not all sequencing-based biomarkers that we use for standard of care testing in cancer today. So beyond just point mutations, insertions, and deletions, we also include information on fusions, rearrangements, gene amplifications, and even protein expression, which is immunohistochemistry as a standard form of testing in the lab. We also include complex logical combinations of their alterations, and I'll give you an example in a second. So the example you heard about today with non-small cell lung cancer and its sensitivity to the drug Erlotinib really started out with an approval based on a single alteration, the EGFR L858R mutation or exon 19 deletions, with a response to therapy that was predicted to be primary sensitivity in the metastatic setting. Well, as we're starting to learn more and more about primary resistance and acquired resistance, we now need to be able to represent information about co-occurring alterations. In this case, the same EGFR L858R mutation now with a T790M mutation, which instead of conferring sensitivity, now confers acquired resistance to the very same drug. So you can't just say I'm EGFR positive. That doesn't fly anymore. You really have to know the co-occurring alterations and how that might impact the sensitivity to the drug. And not only do we have to create and relationships, we have to create not relationships and or relationships. So here's an example from colon cancer and Cetuximab where you can't have a mutation in any of the alterations that occur in this variant group of KRAS or NRAS in order to be able to be sensitive to drugs like Cetuximab in the metastatic setting. And not only that, when we actually start to really look at the evidence base for this, different organizations have different levels of evidence or different specificity that they go into. So the FDA has approved Cetuximab for KRAS exon 2 wild type. NCCN extends that to exons 2, 3, and 4. And so you see that the knowledge is growing and growing, but the FDA labels are not going to be catching up to most of this, and we're going to need to find different ways of reporting on the likely sensitivity and resistance of these drugs other than their initial approval. My Cancer Genome has continued to grow in our content since 2011, and we're excited about how we're managing to do that. It might seem like we don't have very many genes. We cover 56 genes. Clearly, these large panels have a lot more on them, and only 400 variants. But if you look at all of the disease-drug variant relationships that we represent, we have over 700 of them for FDA-approved drugs and over 1,500 in the experimental therapeutics realm. So the permutations on all of this start to add up very quickly. Oops. My Cancer Genome is created by a large contributor network. We have a core curation staff, section editors, and then a larger group of contributing editors. And these editors come from, we have over 65 contributing editors from 21 different institutions in 10 countries. We do not claim that we have all of this knowledge at Vanderbilt. We have reached out to our colleagues around the world who are the experts in these areas to get their contributions to this area of development. I've talked a great deal about content generation in My Cancer Genome. I'm going to spend the last few minutes on content dissemination and some of the challenges that we have ahead of us. So we have two different approaches for content dissemination in My Cancer Genome. On the left are publicly available resources, on the right, clinically integrated solutions. Our publicly available solutions include our website, mycancergenome.org, which is publicly available, doesn't require a login. We want to have a low barrier to entry. We get over 5,700 site visits per week from around the world. We've had requests to translate it into 3 different languages. We don't have any resources to be able to do anything of that ambition. We also have recently deployed a mobile app for the iPhone, and I should have updated it. We've had over 1,300 downloads since June of this summer. So it's pretty exciting. Everyone wants to just be able to carry around one of these mobile devices. This is how we live our lives today. As far as clinically integrated solutions, I'm going to show how we've integrated this into My Cancer Genome, into Vanderbilt's electronic health record, as well as how we've integrated it into a laboratory reporting tool with a commercial partner, Genome Oncology. So I showed you earlier how we were reporting genomic alterations in cancer with that PDF document back in 2004. Well, in 2009, when we started doing our snapshot panel testing, we had, like many, a small number of genes that we were looking at. This is an example of a panel of patients in the electronic health record, and yellow means that an alteration was detected in that particular gene, and when you click on it, you get the list of the genes that were tested for in that particular list of the variants that were tested for in that particular gene, and you can see which ones are detected and not detected. And when you when you click on that particular alteration in the electronic health record, it takes you directly to My Cancer Genome regarding the clinical significance of that alteration. So this is a form of info button, I'd like to say. It's like, if you want more information, you can go and get it. So how do we go then from what we were doing in 2009, or 2004, I should say here, where we were doing this large text report for a single variant in a single gene. I showed you how we were reporting 40 variants in 6 genes, but now how do we go to reporting hundreds of genes where you may have tens of variants detected on a single run with next generation sequencing. And I should also add here, how do we also add in all of the other biomarkers that you're testing for, which might not be next gen sequencing, and integrate all of those together. My new favorite word, I just heard this last week, was a comprehensive theranostic report. That sounds pretty fun. I like that one. So how do we create those types of interpretive reports that are not just going to look at one modality, but multiple modalities as well? So when you think about next generation sequencing, you start over on the left-hand side with your genomic testing modality, and the first thing you need to do is now be able to call these variants. So instead of these hotspot panels where you were only testing for the things you knew what to do with, now you're testing the entire sequence of these genes, and you need to be able to discern which one of these are pathogenic and which ones are not. And so you need to use alternate tools such as sequence alignments, where you have a reference sequence up at the top. You may do a tumor normal comparison if that is part of your assay. And then finally, you need to do a molecular annotation of these variants, where you need to have a known variant knowledge base. Finally, after you've called your variants in the first place, you now need to do a clinical interpretation of these variants. And you need to be able to classify the effect of the variant, whether it's diagnostic, prognostic, predictive, and its likely effect on patient care. And for that, you also need a knowledge base of the clinical effect of variants. And finally, to be able to create a report of variants and their actionability, as well as the variants of unknown significance, so that the clinician can finally make a decision when you hand that report over to them. So what we have undertaken is to use My Cancer Genome as a knowledge base in both that top process as well as this bottom process, a knowledge base of clinically relevant variants for the interpretation of next-gen sequencing. This is an example of how this looks like in the interpretive report, and because I'm running out of time, I'll just go through this quickly. But basically, My Cancer Genome is being used to classify both the variants that have potential clinical utility that you find in your next-gen sequencing assay, as well as reporting the sensitivity to drugs, both in disease and in other disease, which we'll call level 1 and level 2 evidence, and finally, potential clinical trials, all integrated into an interpretive report. And the content on the specific detail pages is also taken directly from My Cancer Genome with a link back to mycancergenome.org. So how do we go from where we currently are to the next generation of dissemination and content curation? We've done an analysis of 12 different next-gen sequencing panels, and My Cancer Genome, which are the genes in the blue, has about 56 genes out of the 810 that are included on all of these panels. But as you can see, what this graph is representing is that these are the genes that only one of the panels of the 12 includes in their assay. and these are the ones that only 2 of the 12 panels include. So 2/3 of the genes are private genes that someone thinks are important that they've included on their panel right now, majority of which are not yet known to be clinically significant. My Cancer Genome does include most of the predictive biomarkers. We're trying to get into the space of including some of the prognostic biomarkers, diagnostic, and pathway as well. Some of the ways that we're doing this include the concept of a learning cancer system, which I believe others will talk about in the course of the meeting, but essentially the concept that we need to be able to aggregate all of our data together on the clinical outcomes of patients and their genomic alterations, because the number of patients with these very, very rare alterations is just staggeringly small, and no one institution is going to have enough patients with each of these variants to be able to do any real discovery with it. So we need to be able to band together and share our data both. And the concept behind the Learning Cancer Center in this concept is that the care of the patient who I'm seeing today is informed by all the patients that looked like them that came before him, and then the care of the patient that I treat is now going to inform the care of the patient I see tomorrow. So we need to start figuring out how to aggregate all of this data. Some of the ways we're doing this have been to create a variant database of 1,000 non-small cell lung cancer patients with EGFR mutations, where we contain about 10 variants on My Cancer Genome. We have over 180 different EGFR mutations, just to give you an idea. Some of them have only been reported in 3 case reports. All right, I'm going to skip all this for the sake of time and just put a last plug in for the fact that we also need to consider our patients and how they're going to consume this information. I believe Pat LaRusso is going to talk about this later tomorrow. But the concept being that we are trying to evaluate how patients' consumption of this material will impact their care and their understanding. So with that, I hope I have shown you that the rise of genomic profiling in cancer is here and here to stay, and it's only getting more and more every day. My Cancer Genome is attempting to become a knowledge base to provide decision support on the clinical utility of those alterations in cancer. We still have a lot of strategies that we need to pursue for content development and dissemination, and other strategies for clinical decision support beyond creation of an interpretive report. And I thank you for your time, and I'll look forward to the questions afterwards.
Thank you, Mia. And I'll tell you, I just downloaded the My Cancer Genome, and it's next to my Uber now. You know, yesterday I was talking to my wife, says, what do we do? The best way to go to the airport after I finish from here. And my daughter jumps in and says, do you know there's something called Uber that you download on your, and now I'm going to go back and tell her I have My Cancer Genome. That's So next is Mickey Williams from NCI, and Mickey will be talking about the analytical validation and more technical and methodical work on this.